بسم الله. يعني أشكر لجنة اللي نظمت المؤتمر إنه أجلستني بجانب أستاذي الحبيب الدكتور بديع الصالح.
العفو
اللي علمني في الجامعة الأردنية واللي خلاني أحب علم الروماتيزم.
العفو يا نصر.
إحنا ختيارنا هو لساته شباب.
الله يبارك فيك يحفظك.
بدي أقدم الدكتور مهدي أبو سلامة زميلنا من فلسطين. الدكتور مهدي حاليا is working in Palestine as a consultant rheumatologist at the Arab Hospital Group, and he is also an assistant professor at the Arab American University in Palestine. في زماناته اشتغل في بريطانيا بس آثر أن يرجع إلى الوطن. فأهلا وسهلا فيك دكتور مهدي. عنده experience واسعة في musculoskeletal ultrasound, interested in large vessel vasculitis، وراح يحكي لنا عن large vessel vasculitis. موضوع صعب مش سهل وراح تعرفوا كيف. تفضل.
Assalamu alaikum. Thank you, Dr. Anas, for the kind introduction, and I thank the scientific committee for the invitation, and well done for putting together this fantastic agenda. So, Takayasu, as you said, is challenging disease, although it's not very common. It's not among the most frequent diseases that we deal with in rheumatology clinic, but it poses a challenge that has many aspects. At the level of the diagnostic challenge, at the level of trying to assess whether the patient has disease activity or not, and that has implications on deciding on the next challenge, which is considering therapeutic options. Yes, we have therapeutic options rich in our practice, but the problem with Takayasu in particular is the lack of solid RCT evidence. And the final challenge is probably how to monitor these diagnoses after controlling their disease. So I'll walk you through those challenges in the next 20 minutes, and I'll try to stick to time. While talking about diagnosis, I don't know about you, but I find medical history fascinating, and you probably guessed it right. On the left, this is Takayasu. Mikito Takayasu is an ophthalmologist from Japan who, believe it or not, described the first case of Takayasu 120 years ago. And on the right-hand side, this is the fundoscopy of the 21-year-old girl that he presented 120 years ago. He presented that at the 12th annual conference of ophthalmologists in Japan. Unbelievable. At that time, ophthalmoscopes were not developed to take pictures. So this on the right is his hand sketch. This is his drawing, showing sort of like a wreath-like circular aneurysms and abnormal blood vessels in the retina around the fundoscope. And two of his colleagues in the same conference presented similar cases with similar fundoscopy, but with absent radial pulses. So these were the first documented cases of Takayasu that long time ago. Takayasu is a large vessel vasculitis. It affects large vessels and medium vessels, and it shares that with another condition, which is giant cell arteritis. And in the UK, where it is very common, I had plenty of cases of giant cell arteritis, not many Takayasu because it's rare. And I'll try to differentiate between them. Probably the striking difference is the age. This is probably arbitrary, maybe it needs updating. We all know and probably learned that usually Takayasu less than or equal to 40 years of age. However, that I will show you in the next few slides, that needs updating, that needs probably pushing up a little bit and considering other aspects, especially imaging of the disease before you call it GCA or Takayasu. You can see that there is a female predominance in both of these conditions, but there is a difference in geographical distribution. We know PMR and GCA, they are very common in the Northern Hemisphere, in Europe, they're less so in the Middle East, and in Asia, Takayasu is probably more common than other parts of the world. When you look at the angiographic or arterial distribution among the two conditions, now it's what's accepted in the field of GCA, especially with the advancement of imaging, that GCA can be split into two, cranial GCA and LV GCA. And from my practice with ultrasound, a typical ultrasound scan of GCA case, suspected case, in addition to the temporal mandibular arteries, you have to examine the carotid, vertebral, subclavian, axillary down to the brachial, and all easily accessible with ultrasound. But I find it very hard to differentiate between LVGCA, having looked after many cases, and Takayasu itself. Yes, age needs to be taken into consideration, but I think also the distribution on imaging, probably there are some subtle differences that needs to be considered. Takayasu, trying to focus on Takayasu in this talk, as I said, female predominance in some cohort, they're talking about 12-1 in some cohort in Turkey, for example. Usually, as I said, the age is less than 40, but that is lacking sensitivity. You have to push it up. Greatest prevalence in Asia, with reported around 150 new cases annually in Japan, for example. I won't spend a lot of time on this, but I've put it here just to try to show you some differences between GCA at the level of the histology of the blood vessel wall. Basically, what started all of this is an abnormal dendritic cells. Dendritic cells in the adventitia, they are gatekeepers. They are responsible for the immune tolerance. Breaking that immune tolerance with abnormal dendritic cells, leading to this cascade of upregulating toll-like receptors and production of interleukins, as you can see here, affecting T cells and interleukin 6, 17, 22, 23. I will mention later on why is that important, trying to look for biomarkers for this disease. Now, considering the first challenge, diagnosis. Now, we all have cases of Takayasu. We diagnose them either by stumbling across them incidentally. We all get referred some CT scans where we've done it for this indication and we found this aorta abnormal, but the patient is asymptomatic. Or they present as textbook classic pulseless claudication, ischemic symptoms, or in between. And those are the challenging, really big chunk of cases where they have those non-specific constitutional symptoms, B symptoms, fever, low-grade fever, night sweats, weight loss, that's unexplained by anything else, where they're not at that stage of pulseless phase, if you like. This is the pre-pulseless phase, they call it in these cohorts, before they reach the pulseless phase where you can easily, when you examine them, find an absent radial pulse or discrepancy in blood pressure. So that's a challenge. So you have to have a high clinical index of suspicion. That's a message not for us rheumatologists, but also for our colleagues in internal medicine and those who are really perhaps the first to come across these cases when they presented them with these constitutional symptoms. Now, there have been some attempts, as I said, to come up with some biomarkers. Inflammatory markers, yes, it's part of monitoring disease activity, for example, but they are less reliable because they're not specific. They can be raised for many other causes, even in cases with known Takayasu when you try to assess disease activity. They've looked at pentraxin 3, which is a peculiar acute phase protein that is, it seems to be outperforming CRP-ASR because it's produced and located within the vessel wall, arterial wall. But again, you have to be careful that it's not specific. It can be raised in malignancy and infections. Looking at classification criteria, again, over the years, in Japan, they tried in late 80s Ishikawa criteria. They modified it in 1995 by removing this 40-year-old age. By pushing it up, they increased the sensitivity of this criteria in classification Takayasu to more than 90%. 1990 ACR criteria, again, the age is the limiting factor. Fast forward to 2022, the ACR-ULR classification criteria, they introduced or put more weight to the angiographic or imaging characteristic of the disease. Sorry if this is not projecting well, but what it says basically, once you diagnose Takayasu, mind you, this is a classification criteria. You don't use it to diagnose, you use it to classify and maybe harmonize the cohort when you consider doing research and studies. But once you classify someone with Takayasu, this is a point-based system where you add points and you can see maybe there's a heavy weight for when you consider imaging at the bottom to the more blood vessels involved, the more points they are, you can give them. And in terms of narrowing and aneurysm, also they carry a heavy weight. Talking about imaging, it's becoming an essential part of the diagnosis of Takayasu. And there has been a huge interest, especially in China and Japan. And this is 2025 Chinese guidelines for imaging in particular in Takayasu. That was published in June this year. They sort of put this busy algorithm trying to help us and guide us what imaging modality is best depending on the type of patient that you're dealing with. I extracted what they're trying to say in this slide because that was not projecting well. Basically, they describe using ultrasound, and I mentioned in cranial symptoms, you can easily apply ultrasound and you don't need anything else in terms of diagnosing down to the axilla and brachia, carotid, vertebral, and monitoring disease. Perhaps you need to consider CT MRA in patients coming with chest pain, night sweats, radiating to the back. You need to consider the aorta and its branches. PET CT scan gives you more information, and with the uptake in the vessel wall inflammation. And also it's important to rule out other causes such as infection and excluding malignancy. Digital subtraction angiography, that's falling out of favor. Used to be historically probably the gold standard in Asia, but now it's falling out of favor to the other modalities that I mentioned above. In those guidelines, they suggest that once you diagnose Takayasu and start or induce remission, you need to repeat the same modality that used in diagnosis 6 months after that, then annually if the patient is stable clinically. Also, there has been some interest into coming up with classification based on the arterial distribution. And these are the widely accepted guidelines, Numano classification system, and they help to improve reporting these cases. And they did show, interestingly, that there are variations geographically. For example, in Japan and Asia, you have the aortic and ascending aorta being involved more than the abdominal, where in India, for example, abdominal was more involved. So this is an area that you will see more publication on trying to differentiate between these two cases and perhaps the response to treatment that you apply to them. Again, for us in rheumatology and for other colleagues who are dealing with these cases, we must not forget the differential diagnosis of any abnormality of large vessels on imaging. But what's helpful when you consider this differential diagnosis, it's often that you will have other symptoms. For example, if I'm dealing with patients, it's likely that they will have other features to guide you towards that diagnosis. Giant cell arteritis, I've mentioned that. IgG4-related disease, 25-odd disease with many systems that are involved. Again, you will likely to have some other features to guide you towards that, and infectious aortitis. Moving on to disease activity. This is another challenge. Disease activity, it's not straightforward. It's not just increased ESR, CRB. As I said, even if they are known Takayasu, they are immunosuppression. Yes, they are prone for infection and maybe developing malignancy. I looked up the cohort. This is the widely accepted care criteria or CARES criteria. They basically use the systemic features as one aspect, elevated inflammatory markers as another aspect, features of vascular ischemia, and the angiographic features, as I put it with the classification guidelines. You have to put these together, and if you have new symptoms or worsening in at least 2 of those, you're probably dealing with an active disease in the case. Again, this is a busy slide, but I'll summarize it in one line, and this is very important. I showed you earlier on the pathogenesis on a cellular level. This is an attempt to look at biomarkers that will help us to predict relapse, which is a big problem in Takayasu. What they found in this one, they got GCA cases and Takayasu cases and compared them with healthy individuals. I think 38 or 36 cases of LVV and 14 healthy individuals, and they measured several interleukins and biomarkers. What they found that usually in LVV and Takayasu, they have increased levels of interleukin-1 receptor antagonist, and that seems to be lower compared among those cases of LVV, predicting relapse seems to be lower. So they are more than healthy individuals, but among LVV, the lower it is approaching that certain, there is a figure in the paper, 340 picogram or whatever, that seems to be predicting relapse of the disease. It's an interesting area. We'll probably hear more about this in the future, and it's not still in practice. Allow me to share this case with you, and probably this is what prompted me to decide to talk about Takayasu. This is a girl who 22-year-old female. She's been unwell since her mid-teens with the usual non-specific constitutional symptoms. As you can see, she's been under pediatrics, internal medicine, GPs, etc. She's been treated for various other things, managed as UTIs, infections, H. pylori, etc. She had some sort of abdominal imaging, which was reported normal, echo even with chest pain that she was reporting at the time, and with persistent high inflammatory markers. It wasn't until she was 18 in 2021 where CT angiogram revealed, as you can see, this is wording from the report, extensive, or I would call it severe large vessel vasculitis with left subclavian totally occluded with collaterals and probably on the right subclavian as well. So severe disease. So she's been treated with high doses of steroids. She felt initially better with the constitutional symptoms, but then not so great after that. She went quite rightly on Humira, anti-TNF, between 2021 and 2024. The problem in Palestine, the patchy availability is a big issue, as probably colleagues will share. So it was not consistent. Sometimes available, sometimes it's not.
5 minutes.
And maybe that's affected her response. Fast forward, she was, when I saw her in May, on rituximab and with persistent high ESR, and with persistent symptoms. I hope you agree that she's probably fitting the criteria for active disease. So what to give her? I won't spend a lot of time on this, but I'll try to summarize to you what's available in terms of evidence about all these therapeutic options. Steroids, great. They are great in inducing remission, but they comes with a high rate of relapse. They achieve remission in 60%, but you're talking about up to 80% relapse if you taper them. So clearly, steroids alone are not enough. So I would suggest that we usually, or need to start something else with steroids right from the outset, from the beginning. Whether to start conventional synthetic DMARD or biologic, perhaps that here comes the angiographic classification and the severity of the disease. There is plenty of evidence out there talking about the efficacy of leflunomide and methotrexate in particular. In fact, in this meta-analysis here that I referenced in this slide, they're talking about leflunomide seems to be, and methotrexate, superior to cyclophosphamide in cases with active and refractory Takayasu. When I was trying to find what best to do for my patient that I described to you, and the biologic I was trying to get her on was not available, I stumbled across this paper only in September talking about combining mycophenolate and methotrexate seems to be superior to cyclophosphamide followed sequentially by azathioprine. So I was really considering giving her that till I got her the biologic. I'll show you in the next few slides what happened to her.
3 minutes.
Yeah, in 3 minutes I'll be done. TNFs, no RCTs. Extensive publications on case reports, open label studies. It seems to work. TNF work for a lot of things in rheumatology, but it's all observational studies. Yes, they have a place. I would use them, but I try to compare them with IL-6. I have to declare something. I'm a big fan of tocilizumab when it comes to LVV. I enjoyed good results treating GCA and good results treating Takayasu before. So I probably have some bias towards IL-6, and that's the drug I was trying to get this patient on. There was one only RCT from Japan. It failed to meet the primary endpoint, but if you examine the primary endpoint, it was stringent. It was time to relapse, considering subjective, objective, and imaging, etc. And it was underpowered, only 36 patients. Despite not meeting the primary endpoint, it favored TOC over placebo. So it does work. JAK inhibitors, very briefly, plenty of studies, not RCTs. They talk about tofacitinib and parasitinib being effective. And don't forget at the bottom, select GCA is the newly published upadacitinib efficacy in GCA, and it seems to be working. It does work. So maybe you can extrapolate some evidence there. Rituximab, not a great. Case reports only. It might work. I've got a case who's fine on rituximab. I don't know whether rituximab is keeping her at bay or other things. So what happened to this case? I got her on tocilizumab. Despite a delay, 2.5 months, got her on IV, not the subcutaneous as the study suggested, had 2 doses. She is due the 3rd dose today, actually, and her ESR after 2 doses dropped from mid-30s to 2, and she certainly feels much better. Brief point about endovascular and surgical intervention. The bottom line, don't attempt to do anything when the artery is inflamed. Wait if you can, if you want to consider any intervention. Disease monitoring, what to do with them. After a month of high dose of steroids, and you have to taper them, as you can see there, maybe GCA style, and you have to monitor them using all those aspects. Quick points about using statin and antiplatelet. Statin, they seem to have a pleiotropic effect, irrespective of lipid profile in this meta-analysis that I referenced here. Antiplatelets, I would keep them probably for those with ischemic symptoms, not for every patient with Takayasu. Finally, this is the final one. This is another case who came to consult with me only recently. She's got a diagnosis of infrarenal, only infrarenal, stable for 3 years on methotrexate and every 6 months rituximab. She's getting married in 6 months. What do I do? Clearly, she's asymptomatic, ESR suppressed, brilliant. So the first thing, I switched her to azathioprine, and I'm planning before getting married to repeat imaging, and if that is fine, I'll probably stop rituximab as well. Why is that? But I would counsel her about these things. Obstetric complications are common in Takayasu, especially hypertension and maternal complications, so careful discussion. So allow me to conclude with final few messages. Have a high clinical suspicion, young woman, systemic symptoms, examine pulses, image maybe early. If you can't explain it with anything else, imaging have a high weight, and research is extensive on this. Treat them aggressively, induce remission. And when you finally try to differentiate their symptoms when you're monitoring them, is it due to activity or is it due to damage, narrowing that's already happened? That needs probably a careful consideration. Thank you very much.